This film is intended for eye surgeons for training and education purposes. Viewer discretion is strongly recommended.
Hi, we have a 75 years old male patient. He has exfoliation and a moderately dilating pupil along with a black cataract. And let's see how to strategize and manage this difficult case. I begin the surgery by giving 2 ml of posterior subtenance injection of lignocaine. As I'm expecting a slightly longer procedure, I want the patient to be comfortable. It's perfectly alright if you can just give a peribulbar block as well with massage. Now, as starting the surgery, in the background, let me just write down the strategies which I have in my mind for this case. The difficulties which I am expecting would be, number 1, visualization. Because of the black cataract and the corneal haze, the visualization will not be great. We don't have the background contrast. Number 2, pupil is moderately dilating, so I would want to deal with the pupil as well. Number 3, I'm not sure about the zonular health, and if zonulars are good, that would be a blessing. Otherwise, it adds to one more complexity. So in the slit lamp, there's no evidence of any phacodermosis. It looked fine. So I'll be knowing the zonular health status only once I touch the capsule. So begin the surgery, the side ports are made, the capsule is stained with trypan blue under air bubble. It's important to have a very good staining. Although the differentiation of the blue anticapsule under the black or brown nucleus is not great, but still it is better than not staining it. So I would always prefer to stain the capsule very well even in these black cataracts. So as I'm filling in OVD into the antechamber, I'd just like to highlight the appearance of a thick arcus here. So this thick arcus also adds on to the poor visibility which we are going to have. Time to create the main incision. The globe is stabilized with the stabilization ring. I don't want to have a long intracorneal length. A longer intracorneal length makes maneuvering difficult, and there is an increased risk of descent membrane detachment happening, which is more likely in these elderly patients who have got not a very healthy cornea. And I'm going to use a 2.8 mm keratome to create my main incision. Now, before doing the rexis, I would like to use the pupil expansion device now itself. The pupil is measuring around 5 mm. It looks all right, but because the density of the nucleus is too huge, I wouldn't want to take any chance, and I would like to just get the thoughts of the pupil out of my mind so that I can focus on nucleus management peacefully. So I prefer to stabilize the globe with my second instrument, and the B-Octa device is gently navigated in the antechamber, and it is first kept on the surface of the iris. As this ring is slightly longer, you may not always have the entire BX ring in the antechamber in a single go. In this case, it does. So now it's positioned appropriately so that I can start doing my engaging the notches. So in this case, I am engaging the first pair of notches through the main incision itself. Some amount of blood has entered the anterior chamber. I switch the hand. I just go into the side port now, engage the base of the W, and then negotiate the next pair of notches onto the pupillary margin. And in the same position, the third set of notches is then being negotiated. I'm finding it a little bit difficult to visualize the base of the notch. So I'm just trying to prevent the eyeball from going away with my second instrument so that I can see the base of the W so that it can be pulled centrally and then negotiated. So as I'm not holding the base of the W, I'm holding one edge of the notch which is engaged now, and then re-grabs the second notch, and then it's gently negotiated under the iris. So now we have got 3 pairs of notches engaging onto the pupillary margin. Mind you, this is a rigid pupil, and in such situations, the last pair of notches can be technically difficult. The one reason is it's gone so periphery, I'm really unable to visualize the end. In the second attempt, I could go and grasp the place where I intended to, and thankfully, this last pair of notches, engaging them was not so difficult. So now we have an excellent pupillary dilatation. So the pupil has been taken care of very efficiently. So now I can focus about just the nucleus management. when you're trying to deal with more difficult cases, I think it's important to break down the difficulties into multiple steps, and then we can address each of them. The pupil has been taken care of now. So now to deal with the nucleus, I need to ensure that my rhexis has to be reasonably large. So if you have a smaller rhexis, then there's always a risk of putting extra stress on the rhexis margin when managing these large, bulky, dense nucleus. So my goal is to have at least about 6 millimeter big rhexis here. The pupillary dilatation would be around 7.5 millimeter. So I'm just keeping that as an reference point. I'm then creating the rhexis of about 6 millimeter. So rhexis is done, and thankfully it turned out to be of a similar size which I had planned. Gentle hydrodissection needs to be done. Before that, I'm just burping out some OVD. The capsule is lifted, and using very little fluid, I'm just doing a gentle hydrodissection. We need to remember that the capsule is very inflated because of the bulky lens. There's no epinucleus in cortex, and invariably the capsule will be thin. So hydro procedure has to be very minimal. There is some amount of blood in the antechamber which is obscuring the visualization a bit, but it should be fine. Now is the time to perform the emulsification. Again, as we know, as I keep saying, I usually prefer to expose the phaco tip a bit longer when I'm dealing with these dense cataracts. This helps me to reach the bottom of the trench quite easily while trenching and also while doing the lateral separation maneuver. I'm just aspirating superficial epinucleus. Viscoelastic is replenished into the eye. So again, my go-to strategy of nucleus management in such dense nuclei is always going to be the classical 4-quadrant divide and conquer technique. Now is the time to begin sculpting. I prefer to stabilize the nucleus with my second instrument, and then the sculpts are being done. The probe moves from the subincisional area directly to the opposite quadrant in a smooth, non-jerky way. The power which I set is 90% torsional, and as the first 3 or 4 trenches are completed, I can see the horizontal striations appear now. The nucleus is rotated, and it's a very heartening to see that there is no zonular weakness at all. Nevertheless, having a habit of stabilizing the nucleus with the second instrument always is a good idea, and it comes in handy when the nucleus is mobile. The nucleus is rotated. So now we have the fourth and final groove which is being created. Very slowly and carefully the trenches are created. The feature which I would want you all to appreciate here during the entire sculpting process is at no point did we ever see that the nucleus was being pushed in forcefully or there was any jerk. The transverse striations are very clearly seen in these dense cataracts, so I need to continue to trench until these striations fade away. So that's an indirect indication of the ideal depth of trenching before attempting the lateral separation. So the sculpting was being done in a very controlled manner. You can literally see that the lens matter in front of the tip just melts away. So there is no jerk or physical force involved. So this is the ideal way to sculpt, which ensures that we don't put any stress on the zonules. Now I've reached the almost bottom of the nucleus. It's about 85 to 90% depth. I'm visualizing the trench. I feel that the central part still has a little bit of a thick posterior plate, so I'm going to trench the posterior plate. You can clearly see the color difference. The central portion is slightly orangish or brown compared to the much more darker peripheral parts of the trenches. So clearly the trenches now become much more darker, and that is an indirect evidence that posterior plate has become reasonably thin. So I continue to trench until I feel that the color of the floor of the trench has really become dark and the striations have significantly faded now. Let me pause here and just show you how the striations would be when the trench was 50% thick. You can see a lot of striations in all the 4 trenches, But now it's a time where the striations have significantly reduced in intensity. Now, this would be the right depth probably to attempt the lateral separation maneuver. The two instruments are then placed at the bottom of the trench, and carefully the lateral separation maneuver ensures that the posterior plate is cracked. It doesn't crack in the first attempt itself. I need to make at least 2 or 3 progressive attempts with the instruments being placed more posteriorly, then the final separation is felt. The nucleus is rotated and these lateral separation maneuvers are continued until we have these 4 separate fragments. Now I've got 2 separate, but the last 2 fragments are refusing to separate. We can see that they're attached at their apex of the posterior plate and it is quite tenacious. It's unwilling to budge. In such situations, just ignore it and I'll show you a trick later on how to manage that. So I'm going to rotate the nuclear fragments and get the free fragments first in the field of attack. I want to replenish OVD so that the cornea is protected. The dispersive OVD with chondroitin sulfate goes in first, followed by HPMC underneath it. This ensures that we have a good degree of endothelial protection, and alongside, there is a very less chance of heat buildup. I'm changing the instrument to Sinskey hook now. Tip of the nucleus is flipped so that the bottom is exposed up, and then the quadrant is emulsified in a very controlled manner. My second instrument is always on top of the fragment as the fragment is being emulsified in a controlled manner. It is just dancing around the tip, gradually decreasing in size, eventually disappears. Time for the emulsification of the second quadrant. In a very controlled manner, the second piece is also emulsified. So now we have to deal with the heminucleus which has got the pieces. The attachment is still at the bottom. It is like a bridge is holding these 2 fragments together. So this is where we use the technique, what we call it as the flip the base and emulsify. This we have presented in the many previous videos as well. So what I'm doing is I put in OVD, flip the base of the 2 fragments up anteriorly. They are now at the level of the anterocapsular margin. So once these at level of the anterocapsular margin, I'm going to use ultrasound energy to destroy this bridge. So this is a safer, easier way to break the bridge of attachment in the posterior plate quite effortlessly. So settings I'm going to use here is the sculpt setting. We're using a torsional energy of about 70% with very low flow rate and vacuum. And with just a short burst of phaco, I can see that this bridge is destroyed and we've got these 2 fragments separated. This is a technique which we call it as flip the base up and then phaco. So the 2 fragments are now separated and they're again consumed one by one in a very controlled manner without any turbulence. The last piece is out. There's a very tiny fragment still moving around. So I just go in with my phaco probe with one hand itself and then go it in the epinucleus mode. The fragment then is get emulsified and pulled out. Time to remove the cortex, which is very little. Now once the nucleus is out, the visualization is excellent because of the red glow. Removing the cortex is not at all an issue because of excellent visibility. The planned intraocular lens is placed into the bag. With the OVD still inside, the B octa has to be disengaged first and then pulled out. To disengage, I prefer to always go in and hold one of these flanges and then pull it centrally so that the notches get disengaged. And then pulling out of the eye is very easy. It's very much similar to the B hex. The OVD both in front and behind the nucleus is aspirated. That's it, the case is done. Side ports are hydrated. These are the first day post-op pictures. To summarize, the brown cataracts visualization can be a challenge, and when we have a moderately dilating pupil, I would not waste my energy in trying to do it without expanding the pupil. And nowadays we have got excellent affordable options for pupillary expansion. So I use the B octa in this case. Planning a very big rexis is a good idea. I always prefer to do the 4-quadrant technique, and in this case we showed a trick how to manage the posterior plate attachment when two fragments are not separating. This is what we call as the flip the base and phaco. So rather than using excessive mechanical force to break the posterior plate, it's easier to just get the bridge in front more anteriorly near the intercapsule margin and then emulsify with the phaco itself, destroying the bridge of attachment with ultrasonic energy itself. The only caveat for this is this can be done only after at least one piece of the nucleus has come out, because if the entire bag is occupied with the 4 fragments attached together, it would not be possible for us to flip the base up anteriorly, simply because there is no space in the capsule bag. So first we have to remove one piece and then create a space, and then it's much more easier to flip the base of the remaining attached nuclear fragments. And the settings which we use here is a phaco emulsification in a continuous format, the typical sculpt setting with low flow rate and vacuum. So there's no harm of it causing any collateral damage. And with just a short burst of phaco, I can see that this bridge is destroyed and we've got these 2 fragments separated.